say fun, but very intense days. And I'm hoping that you'll be able to sort of make it through this last little leg of, I shouldn't say a little leg, but this last leg of the program. And so I'm going to talk about some implementation issues that are sort of related to integrated care. And one of the things that sort of spoke to me is that when I was in one of the other sessions earlier today where our colleagues from the Philippines and from Thailand were talking about how do you integrate mental health services into HIV care as part of the Chimera grant. It really sort of spoke to some of the basic underpinnings and the needs to be able to do that. And I'm going to focus a lot of this talk, at least the first half, on people who inject drugs. And part of what we have to sort of think about and why the studies in Thailand and the Philippines are integrating mental health into HIV treatment services is that we have to treat a patient who comes before us. And our patients don't show up with a single condition. They show up with an array of things, and many of them travel together, such as HIV, opioid use disorder, depression, hepatitis C, tuberculosis. There are all of these things that sort of travel together. And even though that I'm double boarded in a couple of different disciplines, most clinicians are boarded usually in one area. And they don't necessarily feel like they have the expertise to do that work. And so all of these things are intersectional, they relate to each other, and they have an impact when untreated on many of the other conditions. So it's important to think holistically because the person you're trying to help does not come in with just a condition of HIV. There's oftentimes many other things that we're sort of having to think about. Now, there's a couple of frameworks out there that sort of think about integrating service delivery. And here's one that's really quite good and comprehensive, and a lot of people put some work into this. And they really talk about many different levels of integration. And so we heard a little bit in the other room about the collaborative care model. That's kind of the initial stage of integration, where you have coordinated care, where people communicate with each other, they share responsibilities, but they're still siloed systems of care, but you collaborate in order to make patients get services. And so it's basic collaboration at a distance, if you will, and that is a model of integration, and the collaborative care model is probably the best example of how that is done. There's the sort of next level where you co-locate, where you bring in, let's say, the HIV doctor and the TB doctor or the mental health doctor, and they sort of hang around in a similar building or in a similar system so that patients can easily walk between those kinds of services. And this is on-site collaboration, different providers doing things, and you might have a shared medical record where you can communicate with each other, and you can really sort of case manage together. You can bring people together to talk about cases. And then, of course, there's integrated care where you actually have an integrated practice, where the team is working in harmony in the same setting and taking care of the full patient overall. And there's some nuances, there's some gradations even within that particular model. And this particular standard framework for levels of integrated care is a really helpful review for those of you who are interested in that. And what you can see that if you go to this, and you can have this slide, don't you worry. I can't even read it from here, so you'll want to read the book. But basically, it talks about the key levels of communication, the physical proximity, and the practice change. So the last one, a fully integrated care model, is a practice transformation of what you're doing. And it doesn't mean that one is much, much better than the other. We've not gotten really good at testing one model versus the other because healthcare systems in the implementation environment may not be ready to do some of that sort of work, or it may need to be a sequence of things in order to get there. Now, generally, when you look at systematic reviews, there are a handful of major barriers and facilitators that we think about as we're moving through this process. And so from the patient level perspective, we're really getting out into that socio-ecological model there. But for instance, I know in America, like I have friends who have a sore throat, and they don't want to talk to the primary care doctor. They want to go to the ear, nose, and throat specialist because they feel like the quality of care that they're going to get by the expert is really, really so much important. So there may be concerns that the quality of care that they're getting may not be as good, but if you saw Dr. Haddad's talk earlier on hepatitis C, the primary care clinicians, even when we had these horrible interferon-based treatments, the cure rates were absolutely equivalent, even though people might have felt like you needed to go to the liver specialist in order to get that care. There's some stigma in terms of how the services might be delivered. For example, if you're a patient and you have a community health center that's in your clinic and you walk into an area and somebody sees you go in to see the HIV doctor, might there be some sort of stigma related to seeing who's there? But on the other hand, there may be increased convenience. There could be stigma that happens in the opposite direction from the patients, where they might say, I don't want to walk into that clinic that says infectious disease services, all right? So these things are all part of the factors that go into how the patients can perceive the services that are there. From a clinician factor perspective, when clinicians are asked to do something that is not part of their traditional skill set, and I will say that even as an infectious disease specialist, I had many of my colleagues who would not treat a major infection called hepatitis C. They really felt like that was the liver doctor's problem. But it's an infectious disease, and they had to learn those sort of skill sets. So there's the issue of confidence in co-managing patients when they're not specialists. What is the workload? Oh my gosh, this is so much harder. Am I going to have to do more with regard to that? Is there concerns by the specialist that if they hand these patients over that they're going to be really mismanaged by people who are not experts? And then of course I've talked about there are the perception that there's a community discrimination, and if you're in a fee-for-service system and you want to get paid, you want all of those patients to come to you in a specialty care setting or the primary care setting, so you want the patient load in order to have the reimbursement. So there may be some other sort of drivers depending on the system that you're in. And then of course, in order for this to work, there really has to be sort of leadership support, what I call executive sponsorship in order to do that. You have to have space. We're doing some work in Peru, and I'll talk a little bit about it, but one person said, I don't know where I'm going to be able to see my patients. Each day that I do HIV clinic, they move me to a new closet in order to do that work. Shared medical records. You know, for the longest time in the US, the sort of substance use treatment information could not be shared in the regular medical records, so that may be some other issues. And one of the things that's really important is that, you know, there has to be sort of from the executive leadership where they set expectations. It is our expectation that you will begin to take care of these sorts of patients. And so, you know, you have to sort of set the expectations. The clinicians need to be supported through that. And then, of course, if you can, you reward them in some sort of ways in terms of some kind of practice transformation. And then, of course, there are healthcare systems that go into it with regard to funding. We have block funding grants in the U.S. Do they actually support it? If you try to move a clinician who is from another specialty, like a psychiatrist, into your primary care, there may not be funding to do that. Lack of guidelines and some legal impediments that I think Marwan was talking about in the last setting. I'm going to start out by talking about the Ukrainian context. I talked a little bit about that earlier on in terms of disruptions. And then I'm going to move to Peru, and I'm going to use some real-world examples to sort of lay out some of the issues that evolved, that sort of really evolved from that systematic review. But this is an epidemic that's much like Malaysia, that was heavily concentrated in people who use drugs with some sort of transition to the sexual partners of people who inject drugs and to gender and sexual minority populations. Its context around healthcare grew out of the Shamasko system that was developed in 1928, and it's only had a few modifications, and it's really siloed, and its focus is on secondary health care. So the whole notion of primary care was never part of the landscape around healthcare delivery. And this is a place where opioid agonist therapies with buprenorphine first and then methadone is relatively new relative to most Western countries. And then the medications were hindered by multiple factors. But there were some regulatory changes which allowed us for the first time to begin to think about being able to do this. And so in 2016, They had legislation that was passed that said methadone could be provided outside of the specialty setting as long as the clinicians kind of completed at least a one-day training, all right? So they needed to be sort of accredited, if you will, to be able to do that, much like in the U.S. where our buprenorphine providers used to have to do an 8-hour course. And then there was some pilot feasibility testing, which I'll show you about. That's some of our pre-implementation work that we did. And then a couple years later, they abandoned the whole world of addiction treatment, and they said, you're part of psychiatry. So they created even an integration, at least across the higher level, that both psychiatry and addiction is important, and that's going to be important in the next part where I talk about integrating mental health services into addiction treatment setting. And then, of course, the funding structure changed in 2020. So this is a place where there was a lot of movement. It's no wonder that Putin was scared to death. This is a place that was shaking and moving along the way. But they created a national healthcare system where all of a sudden they said, we're going to focus on primary care, and that is going to be our mandate, and we're going to pay them for those services, all right? So all of a sudden there was an opportunity to be able to make changes in primary care. So anyway, what we were sort of looking at as part of our pre-implementation work was what were the sort of barriers and facilitators. The patient level outcomes is, they said, okay, well, we're already used to this place. You know, we're used to all the bad stuff that happens to us, but what's going to happen when we move to a new site? Are they going to move into a site where there might be people from their community who might see them? You know, would it reduce or alter the stigma? And there were some variations on that. And then would there be sort of increased trust in the clinician because they would be seeing the provider who would be doing both things for them? Or did they want their lives completely separated so they didn't have to talk about those sorts of things? There were some provider level concerns, and the specialists, the addiction treatment specialists said, you know, those people over there are not going to take care of our patients. They're not going to be firm with them about how they are taking their medications. And the primary care providers said, quite frankly, we're a little afraid of these people. These are dangerous drug users, and they're going to come into our clinics. And what about HIV? And what about tuberculosis? And are we going to have an outbreak? So there were, I think, legitimate concerns. And they said, we don't know how to deal with these things. This is not part of our training. We're good at diabetes and we're good at hypertension. But those things, what the AIDS clinic did, or the TB clinic, these were all separate systems, were completely different. And one of the things that when we were doing our work is they said, if we're going to do this, we need to not have a training and get thrown under the bus, because if something comes up that we didn't learn about or that we forgot, are we going to be able to do that? And then they also said, why would we want to do anything more than what we're already doing? We're already, this is at the beginning, we're already getting paid a lousy salary, so why would we do that? And what we did before, and this is, you know, right as the sort of ERIC sort of strategies and the taxonomy came out, so it was right about at that time, is we said, all right, what are going to be our implementation strategies that we have to put in place in order to make this happen, all right? Remember, it's the difference between letting it happen in 17 years or making it happen. So we did a pilot study to sort of get some outcomes, and we actually found that in a couple of clinic settings, primary care clinics, they did just as well as they did in the specialty care setting. But we learned very quickly that the stereotypes towards people who inject drugs or people with HIV, those stereotypes, the attitudes towards them actually got better. So that was a good sign. So one of the concerns up front was that there would be increased levels of stigma in the patients. We measured that early on, and it showed that they actually felt safer and more comfortable walking into these settings. So what were the sorts of things that we had identified that were problems? There was a lack of confidence. So we basically said that we're going to use ECHO because we thought it would create a sort of a collaborative group of learners, and we've learned a lot about that from Dr. Haddad. We had to think about the dose. We started off mostly weekly sessions, 1 week for HIV, 1 week for TB, and 1 week for addiction treatment, because we were trying to cover 3 different conditions. And then we did a little bit of work around having them do some quality check. And then the other sort of thing was they just said we don't have enough money. So we said, all right, let's create a pay-for-performance system. And there are mixed results in the behavioral economics data on pay-for-performance. Do you have the right amount Is it an amount that is meaningful to clinicians? And is the reward the right level? And then there's a number of sort of variations on that. And then we had to think about what is the outcome. So if you're going to do integrated care, what's really meaningful in terms of an outcome? And we struggled with this, but we had done some prior work in primary care settings to sort of identify some quality health indicators. And so we selected an array using a Delphi method. Primary care, and I'll go over what they were. Some primary care things, you're supposed to, screen for blood pressure, screen for cholesterol. They're the standard things that you do in primary care. And we actually had a Delphi method to figure out which ones were the most important. And then we created a handful of ones for each specialty condition, for HIV, for tuberculosis, and for addiction treatment. And they were sort of standardized measures that there was general agreement on. Even when we were doing this, we had some voting on it, and they wanted to do mammography at age 35, and we just said, I'm sorry, the WHO doesn't support that. We can't support that. So we used the international ones and we went back to them. So there was some change. You all have heard about Project ECHO, where you have these sort of learning collaboratives, the democratization, and trials that actually show that it works. So that rather than have people march to and fro to every single sort of condition that they need to get treated, they would actually have a network of primary care providers who would actually be guided by specialists, and they would teach and learn from each other through case-based learning in that particular setting that would be connected through video conferencing. And this was important because we were doing this across sites all throughout Ukraine, so you couldn't do that one-on-one. You really needed to be able to reach folks remotely. And so talk a little bit about one of the studies, which was Project Impact. I've just sort of tweaked this a little bit. This is one of those, sort of holy grails of implementation science, a type 2 hybrid implementation trial. And I'm going to walk you through this complicated design. And so this is the kind of thing that you put in a paper or in a grant, but not necessarily that you talk about in slides. So let's just sort of talk about who was eligible for the particular study. We recruited across 29 sites, 13 cities, 39 different clinics, over 1,450 patients. They had to be 18 years or older. They had to have a diagnosis of opioid use disorder. They needed to be residing nearby so that they could actually attend a primary care clinic. We didn't want to make this an issue of inconvenience for patients. And then the second thing that we did was we stratified, which I didn't show in the slide, but we stratified by whether they were newly initiating OAT or whether they were being transferred from the clinic, because the experience might be different. In other words, if you're starting someone new, do these primary care physicians have the confidence to be able to start the dosing and getting them onto medications? And then in the case of the transfer, you could begin to measure some issues around transformation in the stigma in the patients as they go through. But we randomized 2-to-1 to primary care clinics, and then at the center of a cluster, we would have a specialty addiction treatment setting, which also served as a hub or a spoke with these two clinics, so that if patients did get into trouble, they had a safety net in order to be able to get care. We did this in 13 cities. That was geographically quite broad across the entire country with the highest burden of HIV. You'll see the prevalence of HIV is 35%, so it's really high. And then each of these cities had 2 primary clinics linked to that particular specialty addiction treatment setting, which resulted in 26 primary care centers and 13 specialty care settings for a total of 39 sites. And then what we did was we looked at our implementation strategies. So relative to control, getting treatment in an addiction treatment specialty setting, we had our ECHO, which we designed for integrated care, and I talked a little bit about the dose, the actors and the recipients and all of those other sorts of things. And we haven't measured the fidelity to ECHO, but that is one of the outcomes that we will measure. And then we had our pay for performance. And we've learned a lot about ECHO this week, and I briefly spoke about pay for performance, where each thing that they did, they would get rewarded for, and if they achieved a marker of 80%, they would get a bonus on top of that. And then, of course, the next thing that we did was we followed them for 24 months. And it was the idea that it might take some time for learning, in order to be able to sort of achieve the skills so that they could be confident that they would do their work. And our 24-month outcomes were both efficacy and implementation outcomes, and it was the percent of quality health indicators that were pre-specified, and the primary outcome was the composite score, which was a combination of both primary care quality health indicators and specialty care. And from the implementation perspective, we looked at some of the provider attitudes. Did they like what they did? Did they like the patients that they saw? What were their levels of stigma, discrimination, stereotypes, and all of those other sorts of things? How they really thought about evidence-based practices. This isn't necessarily a place that adopted evidence-based practices. Provider confidence. Did they feel that they were comfortable in managing these patients with these specialty conditions? And then the fidelity to the echo. And one of the things that we've been doing with Dr. Haddad is we've been trying to create some fidelity markers, which is one, did you attend? Did you engage? And did you present? Really creating a gradation scoring system for that, which has not been done prior to now. And so what we did was we said for the outcomes, we would both measure self-reported at 6-month intervals. That means you have to have a fairly high retention rate. Our retention rate in the interviews was 88%, so we've done very well with regard to keeping up with folks. And then we said we're going to look at the electronic medical record, and we're going to try to have an objective. And I'll just tell you that you get better quality health indicators when people self-report, but the bottom line is the outcome ended up being the same for us. And then we surveyed the clinicians serially to see what happened with them over time. We had 9 primary care health indicators. None of them would be a surprise for you. And then with regard to HIV, if they were negative, did they get screened? If they were positive, did they get a viral load? And did they get them onto antiretroviral therapy? For people with tuberculosis screening, if they had TB, were they actually, without TB, were they getting screened at least annually, which is recommended? And then people with TB, were they getting monitored and completing therapy at 6 months? And then, of course, for methadone, were they able to shift their patients to take-home dosing? Did they get them on an optimal recommended dose? And did they stay on the methadone treatment? So let me just give you the 30,000-foot view. This was a paper that was presented just a week and a half ago in Munich at the International AIDS Conference. So you all are the second people on the planet who are seeing this. And so this is really the composite quality health indicator, specialty and non-specialty together. And you can see that the curves diverge really quite early in favor of the primary care outcomes being superior at every single time point. Now let's break it down and see what happens with regard to the other sorts of indicators. And here you see that the gap widens quite markedly because the primary care physicians are doing what they're trained to do. So those patients get much better. And what is the rationale really for this? Patients with substance use or psychiatric conditions die on average 10 to 25 years earlier than those without those conditions. But they don't die of overdose so much as they do from non-communicable diseases that you can screen for and treat in primary care settings. And so this is really where the money is. We're talking about HIV and we're closing up in on those 95, 95, 95 gaps. We really need to be thinking about those non-communicable diseases that are going to sneak up on our patients who are in specialty care settings and who are not getting the recommended primary care services that they need. But surprising to us, at least during the first 6 months, the quality health indicators for the specialty care conditions, this is what they're learning. Remember, this is what they're doing with ECHO. At 6 months, we did not see a result. So when you do these trials that are really short-lived, you may not see the outcome that you anticipate because collaborative learning takes time for people to not only absorb the information, but to also translate it to their clinical practice. But by 12 months and thereafter, there was actually a benefit because the clinicians moved towards the practice of taking care of the patients. Now, let's switch to the electronic medical records. The good news is that it showed the exact same thing that we had seen before. It's just that the levels were lower, and that's not surprising. people over-report. It's kind of like with adherence. Yes, I take all of my medications, but I took 90%. It's that sort of thing. And we would expect that, and we wanted to measure both to make sure that we had some kind of proxy to be able to take a look at what might be the difference in those outcomes. And there are problems with actually electronic medical records. People may not report what's there, but the bottom line is that the trend and the outcome over the period of time remained relatively consistent for this. Now this is a quick preliminary analysis, and this was a really interesting learning tool for me, and I don't know how much of it. We need Donna to come in back here and to tell us, because we changed things that were happening over time to really tell us whether the policy change with the national healthcare system influenced some of this. But the pay for performance indicators did not start separating until the end. And maybe perhaps there was the perception that I'm now finally getting enough money to make this a difference, or they got sort of used to that in the setting where there was, maybe that served as some kind of audit and feedback because somebody was auditing their performance in order to give them their money, so it might have been a sort of an alternative audit and feedback. Remember I said in clinical trial and systematic reviews you get about a 4% benefit? Maybe that's what we're seeing here. But anyway, you do see a sustained but much later benefit, but nothing early on. And this is true for both primary care and for the specialty care quality health indicators. Let me sort of move and shift the landscape a little bit. Still in Ukraine, but now we're going to talk about the people who've actually gotten onto opioid agonist therapies. This is a protocol paper that you all can look at, but as part of our sort of pre-implementation work, we sort of really tried to understand what the patient and the clinician concerns were. And the patients they preferred integration because there was an added layer of stigma of having depression, and if they had to see another person, they felt like that would be too much. And that the serotonin reuptake inhibitors were too expensive. We actually made them available for the entire trial so that factor of cost would not drive the outcomes. Not necessarily a pragmatic trial, but nonetheless, we wanted to take a look at the integration issues and trying to keep that as one of the outcomes from being driven by the unavailability of the resource that they were trying to get. And then the clinician concerns was that these addiction treatments were a subspecialty of psychiatry, but they weren't practicing that much of it in real life. They weren't really convinced that they had the skill set to be able, much like for the specialty conditions, and that they were basically paid too little to take on more work, so they needed tools that were quick and rapid and fast. And they didn't have the budget, so we purchased that as part of the study. And what you can see is it's once again one of those complicated designs, but it's very similar in terms of it being a cluster randomized trial. And what would happen is they would be baseline assessed, and they would either get randomized to what we call a rapid type of treatment where a non-physician could do it. They could screen them using a rapid screening tool, PHQ-2. 2 items. Does it get any easier than that? Even when you go to the 9, that adds a couple of extra minutes. Time is money for these folks, and it's more work. If they screen positive, they did a confirmatory MADRS test in order to take a look at that, where they can also monitor the patient's response. Once again, it's not taking a physician to do this, so we use validated tools to be able to do that so that there could be considerable task shifting. And we allowed them to decide how they wanted to do the task shifting with that. And they either got the echo with or without the pay for performance. And we had service level outcomes. I'll give you a little bit, and also patient level outcomes. And let me just show you that across the study of the 4,000 plus patients, we created a cascade because this is where we're going to look at the markers to see whether they did they screen them. We got 77% screening across the board. That's pretty darn good. All right, now we're going to stratify by which arm that they were in, whether they were evaluated, so you have to get evaluated, screened, evaluated, all right, and the evaluation means that you diagnose them because it does require a physician to give them a diagnosis. This is where you can begin to move things to pharmacies at this particular time point. Did they get on treatment? So once you get a diagnosis, did they get on treatment? And then were they retained on treatment for 6 months? And what this does is we sort of set this as the stage for our implementation gap that is driving all of our analyses here forward. And then we have an extension of the implementation process that happened after the war broke out. We've got some other integration studies. We're looking at sort of integrating these kinds of services into primary care clinics in a rural setting in West Virginia. We're using Niatex to guide the process improvement. We're using set tools in order to do this, and it is a type 2 hybrid rather than a clustered randomized trial. And then I'm going to spend a few moments on some of the early work that we're doing in Peru and conceptualizing the way that we're thinking about some of these. And one of the things that was, I think, really remarkable about the way that this particular study came across is there was some coalition building right at the beginning. And so, you know, for those of you who, most of you haven't been to Peru, but I know Sten has, it is a hotbed of competing investigators and researchers and public health folks and NGOs who are all in this. And so one of the things that we said was, all right, there's a lot of things that can be done here, and there's a lot of stakeholders who want to do it. And so what we did was we met with the Ministry of Health and the HIV division, and we said, tell us what really keeps you up at night. What is it that's really driving you to be able to want to make change? So we had an extended discussion, actually over a couple of different visits. And what we did was we prioritized 4 different things. And the first thing, and once we identified them, we went through and says, what is the one that is really the most important for you? And it's not integrated care, it's decentralization of care, but it's really the other side of the coin, where you're moving patients from these large specialty care settings and transferring them. They have clinics with HIV, with patients with HIV that are 5, 6, 7,000 patients strong, where people come in and spend the whole day at the clinic. And the whole idea was, since 2019, they had been saying, all right, our guidelines say to decentralize to primary care. And this is something that's happened in Malaysia. I think in some cases successfully, but there may be some nuances around that. And that was really bothering them, because I think they had like 600 patients who had been sort of transferred to these care settings. And they said, of course, we want to figure out how to decentralize not only in urban Lima, which has 12 million people, and I can tell you, if you try to get from like just a couple of miles down the road, you can spend an hour trying to get around. So it's tough to get around in these settings. And he also was interested in how you might do this up in the most remote areas where they were having a tragic epidemic along the Amazon River, where the routes of transportation are mostly by boat rather than by getting in a car or a bus or public transportation. We weren't able to take that on yet, because I think we needed to get the landscape. The second priority that they had set forward was, how do we actually scale up PrEP? And that is a separate project, but nonetheless, this one is mostly related to that. And we have been sort of working on this. We've done a lot of the preliminary pre-implementation work. We're in the midst of getting our Delphi almost done in order to move patients into primary care settings, creating some tools for that. We had to reorganize the way that we thought about systems, because our clinicians said, you know, in the HIV clinics, but we like our patients, we don't want to give them up. And we did some nominal group technique that I'll show you the results of. And they also felt like the patients were going to get lousy care. So we wanted to figure out a way to keep people connected to the primary care clinics that were around them. And then we've decided once again to use Project Echo. We're finding that it's really useful. We didn't know when we first started. I mean, all of it was basically, you know, sort of basic observational studies with a comparison, with nothing prospective. These are now some of the only, in fact, these are the only prospective trials of Project Echo, and we used a type 2 stepwise trial. This is one of the other places besides Eastern Europe and Central Asia where new HIV cases are increasing, and especially in Peru. And the issue around this is that we're looking at a place that's a low and middle income country. They have about 120,000 people with HIV. Incidence is up, mortality is up, And this is where the disease is concentrated, not in people who inject drugs. That's such a very small population of the patients with HIV, but among sexual and gender minorities, over 60% of all the new infections. And Lima is huge, but it actually is where 64%, 2/3 of all the people with HIV are known to be. And we had to do a lot of landscape. We had to understand how the healthcare system was organized into these large, centralized specialty care settings and where the primary care clinics. And as part of their movement to decentralize, they set a minimum amount of criteria that needed to be present. They had to have someone who was what they call capacitated, that is trained to do HIV care, which is an 8-hour session and a 1-week sort of clinical, sort of care area. And they had to have the ability to do HIV testing, they had to have the ability to do viral load and CD4 count, and they had to have on-site pharmacies. So those were the 3 minimum requirements that were needed in order for a place to be designated as a primary care setting. And what we had to do is we had to chronicle them across all of the sites, and I'll show you that. But here is their cascade. And their biggest issue is that retention in care was their big issue, and that's where the biggest gap is from treatment. They get linked, but they don't stay in care because it's really hard to get to these specialty care settings for these patients. But there are multiple processes, that is, multiple types of implementation strategies, which we have actually selected to do this. What else do we know? All HIV care, even laboratory services, are provided for free by the Ministry of Health. It is a very centralized HIV care system. Huge clinics with HIV. They had designated all of these changes, and they had to be capacitated. So what we started out with our problem statement is that decentralized HIV care is an evidence-based practice. It's recommended by WHO, UNAIDS. And the question that nobody has been able to answer in all of these systematic reviews is, how do you do this, all right? They just say to do it, and I've read and I've gone to some of these sites and I've looked at them. The process for doing that, once you start and then move to that, has really never been described. Places have done it, I think, successfully, but the process of the science of doing it isn't really known. We looked through the systematic reviews in 26 countries, most of which were low and middle income countries, and every one of the studies, with the exception of a couple, shows that they are increased retention in care. So we were choosing the right evidence-based practices. These primary healthcare centers tend to be a little bit more agile and accountable, but they may not have the resources and the services available, so we needed to make sure that that was there. And then, of course, they're oftentimes very busy, and they've got many other competing concerns that were going on. And there was this sort of inability to know what the other side was doing in terms of communication. So what we've done as part of this project, we're sort of now in the early implementation phase, is we're almost at the verge of a nervous breakdown. We're almost at the verge of finalizing the transition guidelines, creating the criteria for how you might start by having stabilized patients and moving them, that is achieving not having a detectable viral load, all the way to having some of these primary care settings take patients brand new at the point of diagnosis. We've been working to identify the barriers and facilitators, and then we're going to get into the trial. One of the things that we've done from an implementation strategy perspective is organizational redesign by creating these hub and spokes so that the people whose patients are being transferred are at some level of communication, because they are the ones who are running Project ECHO. And if they're running the Project ECHO, they are communicating directly and creating a relationship with those clinicians. We're using the blended NIATEX strategy to guide practice transformation and support the changes in the way that services are delivered. And we're supporting clinicians and the providers within the primary care setting through Project ECHO. This is the hub and spoke model, where you'll have one of these large HIV clinics, and as they farm patients out, they're able to communicate with each other. So that was part of our implementation. Everybody has heard, at least in a couple of talks, about NIATEX. we're kind of sold on it. It seems to work. And we'll probably learn something from this. One of the things that I will say is that this is the first time Niatex will ever have been used outside of addiction or behavioral health. So this is moving the field of implementation into sort of a new disease state. And we had to sort of understand the landscape by being able to, in order to have our step wedge design, what do these big specialty care settings look like? So across the top, you see the names of the clinics, such as Dos de Mayo, Loaiza, Maria Auxiliadora, and the others. And then what we would do is we would talk about in which region of Lima, because they have administrative districts who oversee these primary care settings. We picked the settings that actually had the ability to do integrated care. We looked at the patient catchment area so that it was at least somewhat similar between them, including the density, the number of people with HIV in the region, how many people had already been transferred to primary care, and we looked at the characteristics of the staffing at these primary care settings in terms of some of the ratios of clinicians to people with HIV and specialty service certification. It's always good to show your design in terms of what you're doing, where you have your control or observation period and going into your implementation phase with our implementation strategies. And then this is designed over a much longer period of time so that we will be able to see if the services are maintained over the course of this 5-year grant. I'm not going to spend a lot of time, but we used the re-aim framework because we were going to try to look for some of the diffusion that happens as places became capacitated to do primary care. And what we did was we defined what it was within each of these domains of the re-aim framework. We looked at whether there was an outcome at the client level. Most of these will be around efficacy, and it was retention and care. We have a national database that took us almost forever to get, but we've finally gotten it, and the cascade of care is actually worse than we thought it was before we wrote the grant, not surprisingly. And then, of course, we set our primary outcomes for efficacy about retention and care as people shift to these settings. And then we looked at fidelity to our implementation strategies, such as Niatex and ECHO as our primary outcomes. But we've got an array of others that impact institutions, people with HIV, and then, of course, we've got some to see what do the policymakers think as they learn about some of these processes. Some of the sort of pre-implementation work is some nominal group technique that many of you have had the opportunity to watch in action. And so one of them was people with HIV at secondary healthcare centers, these big clinics. And what they perceived with the highest vote was that stigma within the community would be too high for patients to do well in the primary care clinics. And that was number 11, so that's one set of stakeholders. And that was the people who were actually probably quite satisfied with their care where they were. And maybe that was part of their reason for not wanting to get transferred, but that's who we surveyed because we needed to hear their perspective. But we also did the same thing with staff at a specialty healthcare center. And it wasn't so much about that. That was part of their concern. But they really believed that the lack of confidentiality and stigma. So there was some interrelatedness that was there, but then there were other factors related to the competency of the clinicians at those other sites. And then, let's see if I got that. And then what we did was we had 3 very large nominal group techniques of maybe 13 to 15 people in them that we operated at one of the launch meetings where we had stakeholders from the district, from the primary care settings, from the specialty care settings, and we had a community stakeholder group, and we just randomly broke them into 3 groups, and we asked the question of what gets in the way of transferring patients to these sort of settings. And the highest votes, we had 3 of them, actually 4 of them that were pretty darn similar. Concerns that the patients with HIV would get really lousy care was really high, that there was not enough infrastructure, and so there was obviously a knowledge deficit that maybe many of the people there did not perceive that these sites had antiretroviral therapy, So this is one of the things that you would need to do in terms of correcting the knowledge about laboratory testing. That was a requirement for any site to be able to do that. And maybe it was a perception that it was at any particular site. Lack of confidentiality that might happen in the primary care setting, once again, very similar to what patients and providers at the specialty care setting. And the other thing that was really interesting that has emerged as one of the tools to use is lack of sufficient transfer communication, because the clinicians in both directions wanted to know what's going on. If I transfer one of my wonderful patients from my big hospital clinic, what's happening with my patient over there? And the people who were accepting the patient said, I want to know what's happening with this patient before I take them. And so the idea, they don't have this sort of electronic medical record. They have a system in place where basic laboratory stuff can be seen, but none of the other sort of stuff. And so a transfer document was actually part of what they wanted to see. This is all work. Where's David? He's over here. David has put this all together. I mean, I'm talking about, we have a ton of other sort of data. He mapped all of this onto the socio-ecological model, so we could think about what are some of the ways that you would intervene at various different levels in terms of implementation strategies, which is what we've done. And then there have been some things, Donna talked about learn as you go. Well, we've learned some lessons as we go along here. We ended up, before we actually randomized the first set, having another site that said, we're really interested in doing this, and we added a fifth hub so that we're randomizing two groups. Once you get into the randomization process, you can't go back and say, oh, maybe we'll add you to this one. That's not really scientifically or statistically going to get you where you need to be. We've done some of the NIATEX training and the coaching and the collaborative learning, so we've gotten started with that really, I think, quite successfully. So we've done well with that. The Project Echo, in terms of the dosing, the content, the coursework, the lessons, and stuff like that, has all been started and is underway. Initially with very high engagement, we've seen a drop-off, so we're going to need to think about some of the fidelity issues. So that's once again one of the things. You don't expect that everyone's going to show up, but you certainly, this is one of the lessons learned as part of that. And so we're now surveying the providers to see what's getting in the way. Is it the timing? Is it